Whereas it's true that only 5% of the population is involved in the military, the truth is that we are still talking in hundreds of thousands of soldiers now that have been involved in this war. And so anybody that thinks they don't know or don't have one of those soldiers in their practice simply is not aware. We're talking about large numbers of folks and their families who are equally involved in this. So I think if a physician believes that this does not affect them, they may want to look at that a little bit more closely.
Joining Forces, On the Mend, is a co-production of Health Partners Institute for Medical Education, a nationally recognized provider of continuing education for health professionals, and TPT's Minnesota channel.
During the summer of 2007, the headlines were full of stories and news reports about the 2,500 Minnesota National Guard members who were serving active tours of duty in Iraq. Even though many of the soldiers are home and have had some free time to get used to a more normal life, there are a number of lingering questions. In this program, we're going to examine the physical and mental health of those returning soldiers. How is the connection between the medical community, the soldier, and his or her family held throughout their deployment? What can be done to strengthen that connection? How will the medical community treat issues that could crop up years from now? With us today to answer these questions and talk about the relationship between the medical community and the returning soldiers are Chaplain Lieutenant Colonel John Morris of the Minnesota National Guard. Dr. Terrence Mogg is an internal medicine specialist with Health Partners Medical Group and clinics in St. Paul. Also with us, Dr. Basil LeBlanc, a practicing physician and the state surgeon for the state of Minnesota, the Minnesota National Guard. Welcome. Always good to see you. Thank you very much. Appreciate your time here.
Thanks.
Dr. LeBlanc, I'm going to start with you first. What generally is the health status of our returning military members?
I'm happy to say that the returning soldiers have done really well. There's been a very low number of soldiers that have been identified with any kind of lingering medical issues. There were a number, of course, that occurred in country, and people sometimes forget that, of course, the majority of injuries are not combat related, but just your standard aches and pains and the things you might anticipate when you strap on 35 pounds of body armor and then slip into a hot, confined space of a Humvee and go down the road. So most of those issues have already been dealt with, and they're doing very well.
What can local physicians maybe expect to see down the road?
The obvious things are going to be any of the trauma-related injuries. However, they'll be dealt with for the most part. Our main concern is those injuries that aren't quite so obvious and that you don't see.
For instance?
Mental health issues are the ones that we are most concerned about, the ones that you simply can't tell by looking.
We're going to talk about that in just a few minutes. Dr. Mogg, what have you seen so far among some soldiers coming back?
I think my experiences echo what Dr. LeBlanc was saying in that the handful of soldiers I have seen have been healthy, coming in for routine exams and follow-up and trying just to get integrated and back in with their physician. I have seen one case of post-traumatic stress disorder. So again, echoing that it's not the physical that I've seen, but more of the mental struggle.
What are those symptoms, by the way, of PTSD?
I look at it as having any flashbacks or thoughts that are interfering with daily life. So having a hard time integrating back into work and family and so on because of the disturbances of these thoughts.
I don't want to leave Chaplain Morris out of the conversation here. What conditions are you most concerned about with the folks coming home?
I think I want to talk to Dr. Mock's experience here. PTSD, it's a label that's commonly used versus combat stress or delayed combat stress reactions. Combat stress reactions often present themselves in the same classic symptoms of that mental disorder known as post-traumatic stress disorder. And I think for physicians, that's an important distinction. and want to get on top of, because you're going to see some delayed combat stress reaction in many soldiers. And the doctors outline some of those, the nightmares, the flashbacks, the hypervigilance, extreme anxiety, even hyperventilating, inability to leave a building because you're scared. It's not very common, doesn't affect a lot of soldiers, but the soldier it affects, it's pronounced. But for most of those, that'll dissipate over time. However, the doctors hit it right on the head. When do these things start intruding into the ability to cope on a day-to-day basis? And alerting people that most of those symptoms disappear in most of us 3 to 4 months after being home. The guy, the woman that it doesn't dissipate in, there's a problem. And that concerns us greatly, because for the person experiencing it, that's hell on earth. And often very alienating, feel very alone, don't know who to talk to about that. That primary care physician is going to be a lifesaver. But again, those are not the most common issues. Most common issue, I think, the medical community is going to see issues related to relationships and the inability to get those things to work. So depression, very, very common. Anger, displayed inappropriately, or inability to handle anger, and then all the ancillary things that come out of that. Those two things present themselves in a variety of ways, but are very common in returning combat veterans and their family. Families see that and report that regularly.
But when you're in a situation, in an examination room, and you have a soldier that you're seeing as a client, a patient, how do you start chipping away at that? What questions do you ask to get to this point where you might discover something that is really bothering that soldier?
Screening tools are oftentimes very helpful that you apply to all patients and then see what turns up. Because if you don't ask the question, you're not going to find out that it's an issue. So that's one of the most useful tools that you can use. And also, frankly, you may very well just get the call from the spouse who says, you know, Joe is not doing very well. He's up at night, he's cranky, he's not dealing with the children very well. And so that outside information can be very helpful.
I agree, I think the important thing is to have the information first that this is someone who is in the military and has served over in Iraq. So whether you want to do that with some sort of screening questionnaire for patients who are coming in for physicals, or somehow making it part of the visit. And then once you realize that that is the case, I usually try to focus on how is the things that I normally do in the course of a preventative health visit. How's work going? How is the relationships going? And then once you find out that there's a problem there, then that oftentimes leads to this is at the root of the problem, maybe.
But if you have someone, a patient, who has served in the military, and you think there could be an issue here, but you're not sure, the reluctance to discuss these issues, how do you kind of push that to get them to open up a little bit? Do you have any advice?
I think the most useful thing is to normalize the reaction. As Chaplain Morris said, all soldiers will experience a whole variety of different emotions and feelings, and that's okay. It's only when they start to take over and get out of hand that it becomes a real issue. So in our reintegration programs, we talk about the normalcy of all of these feelings and adjustments that have had to be made.
In Chaplain Morris, some people are just normally reluctant to discuss health-related issues, but with the service-related health issues, the reluctance there might be a little greater. Do you find that among some soldiers?
It depends. We are taught to be very self-sufficient, so particularly for a male soldier, we're not going to lean into questions about mental health. So I find a good diagnostic tool is just tell me how your readjustment to being a civilian is going. And most of us are pretty good at explaining that, hey, you know, this is going well, this isn't going well, and doctors can pick up on that very quickly and go down those avenues where they tell you, yeah, you know, job's really a frustration. Well, what's the frustration? And how are you showing that frustration? Well, I get angry really quick. Really? What do you do when you get angry? You ask those questions and it opens all kinds of boxes, and our soldier doesn't even realize they're revealing their mental health. Now, for some of us, a small number of us, one of the fears about talking about our mental health is that we hold a top security clearance. And we're very well aware that we could lose that clearance if we are not mentally stable. Now, that's shrouded in a lot of misinformation, so a lot of soldiers needlessly avoid dealing with emotional issues, when if they understood more correctly, you can get help, you're not mentally ill, if you're experiencing some general depression, if you're having some anxiety, if they understood that a little bit better, they might be more forthcoming. And I think trying as physicians to say, I'm not assuming you're mentally ill here. I'm assuming you're having very normal readjustment challenges and want to help you with that. We're going to get a lot further into that barrier that a few of us have in talking about mental health issues.
And that's a common experience that we deal with in everyday seeing patients who are not in the military. There's trying to tease out that depression is there. So I think that's something that physicians are used to doing. And we have tools, stepping out and having the nurse go back in and administer a questionnaire that helps go a little bit deeper and see if there really is some depression there. Using those same tools and ways that we deal with non-military individuals, I think helps in teasing out the depression and the anger that you're talking about in the military folks.
You know, we've been talking a lot about depression, mental health issues here, and we've touched a little bit about some of the physical ailments. What about those ailments that you might have when you are discharged that you haven't said anything about? What of them?
That's one of the reasons that we ask all those questions again at all the reintegration programs, and particularly at the 90-day. There will be a face-to-face with a healthcare provider who is going to say, how are you doing? And are you having difficulties with this or that? And so we hope to be able to identify them at that time. And you know, coming forth with physical issues is not really very problematic for most soldiers. They're home now, they've had their welcome, they're glad to be home, and you know, the truth is I did kind of injure my back, and they're interested in getting that established so they can get care for it. So I don't see any real big issues with them being forthcoming about that, because frankly, they don't want to pay to get fixed. It's an Army issue, and the Army ought to take care of it, and we're happy to do it.
Chaplain Morris, comment?
Dr. LeBlanc's exactly right. The more we're home, the more comfortable we are talking about physical problems. And generally, the more aggressive we are in seeking care, and we're going to go to our primary physician more often than not. We're comfortable, we're home, we want to be treated with a measure of care that's available at that primary care physician. So we're going to self-report those things. And some of those problems are not always self-evident. Some of us come home having eaten some pretty exotic food in Afghanistan and Iraq. Not very many of us, but some of us that are out working with the local population have jobs where you have to eat the food. It'd be very offensive not to. Come home with some pretty strange gastrointestinal issues. That'll be a challenge for some doctors because you don't see this kind of third world parasite on a regular basis. And some of the soldiers that I worked with that were part of the early invasion of Iraq who ate off the economy because they needed to, still struggling with some of those issues. So that, you know, it's a small minority. But again, I'd rather know that doctor. It's my local clinic, had a long established relationship, than go see somebody that I don't know and have to reveal all that.
I think one of the helpful things in that regard is that nowadays there's been so much work and progress in travel medicine, so that there's travel programs, there's extra credentialing that physicians get, so that if we suspect something might be going on that's fairly exotic like you're talking about, there's plenty of people around town now to refer to and get help. So.
And we're just talking about the soldiers who have been severely injured, of course, they're taken care of on a different scale. Mm-hmm. And you would probably not see those kinds of injuries in a normal...
Typically not.
Okay. Let's talk a little bit about that. The health-related resources available for members of the military, how good are they?
I'm happy to say that they're getting better all the time. Soldiers that have been in a combat zone or any kind of active duty are entitled to health care, typically 1 year for every 3 months that they were activated. And so that equates to these soldiers to several years of qualification for TRICARE. Our challenge has been to get more and more healthcare systems and physicians to accept TRICARE as a means of payment. But I'm happy to say that we've made major strides in that area.
And Chaplain Morris, comment?
I agree. You know, when we separate from the military, we have the VA system for anything related to our combat experience. If we're still in the National Guard, as Dr. LeBlanc has talked about, 90 days after combat, we go through a full mental physical health review. This is something that's developed over the last couple of years. It's a phenomenal system. And then we have all kinds of ways to help you if we identify things through that system. And then we have this other layer of TRICARE insurance. This is the first war that the government's ever given us private insurance to use post-combat.
And that's what TRICARE is?
Correct. So that gives us purchase power to go out and buy health care for ourselves, which is a wonderful thing. So we have these layers of systems available to us, never before available to other combat veterans. So there's a good network in place. Now it's accessing it. It's the soldier going forth and taking advantage of what's available, and that varies by individual.
And as a primary care physician, when should I be referring back to the soldier to get back into the military system?
I think particularly when it clearly is combat related and clearly something that arose out of their being deployed, then there's no question. If we created the problem, we want to be able to deal with it.
Even if it's something routine that I could treat fairly easily?
Oh no, I certainly don't want to take away your skills and your opportunity to help that soldier. Honestly, it's just things that either you don't feel you can take care of or perhaps need referral. I think it's always best to refer back to the VA if there's going to be an orthopedic issue or something that's going to require further care.
Is it fairly easy to diagnose a combat-related illness or injury?
Yes, it is, as a matter of fact. What the Army does pretty well is documenting who was involved in injuries, accidents, fire episodes, and establishing that line so that in the future, no matter how far in the future, we can go back and say, oh yes, here is where that occurred. We own this one. Let's take care of it.
I think there are some instances where, there are very common problems that overlap, such as depression. Did the person have some depression beforehand? Is that a result of being deployed or not? And I think sometimes that's where it can get a little trickier.
Mm-hmm. You mentioned orthopedic problems. Mm-hmm. Really? Is that a potential sore spot, as it were, with returning soldiers?
Well, one of the most common injuries in any kind of intensive setting would be back pain, extremity pain. Again, if you throw on 35 pounds of body armor and all of the things that you're required to do while wearing that armor, it's easy to envision back injuries, extremity injuries. And a lot of times, soldiers at the time will, they'll say, look, I'm staying here. This is my mission. I'm not going to really say anything because I'm not going to get sent home. I'm not going to take that risk that I'm not going to be able to complete this mission. And they just buck it up and they finish the mission. And then they get home and they think, you know what, I thought it would go away, but it hasn't. And so that's when they seek care.
Sounds like you've had some experience with this, Chaplain.
Yeah, what Dr. Blanc's saying, that's a dime a dozen. That amount of weight you're carrying, and you got to remember, it is hot. And you are doing things that are not part of the routine that you came from, wherever you were in Minnesota. Now you're compressing yourself into a vehicle, you're walking across soft gravel. If something really bad happens, you're jumping out of that vehicle. And you have stuff strapped onto that body armor that adds to your weight. Your pockets are filled. You've got all kinds of things. One twist the wrong way and you've got a lower back issue. And soldiers are routinely, they're bonded to their brothers and sisters they're fighting with. They're not going to let them down for a minor injury. It's going to have to be a pretty big injury for most soldiers to go and say, okay, take me off the battlefield. So when now I'm home and I'm safe and I go to my primary care physician and say, I've had a back problem for the last year and a half. Well, now you're into an issue that started in combat.
And sometimes that can be very challenging because with back pain, it's oftentimes a flare and then a quiescence and then a flare again, or even a period much later, it can be the back just flares up again. And was that related to the initial injury, perhaps? Yeah.
What's the responsibility of the individual soldier, Chaplain Morris, in advocating for his or her health?
Well, I think we've done a great job in our society in trying to train people that you're a consumer of a service and you need to take advantage of the service, educate yourself about your welfare, And we try to do the same with soldiers. The great care that they receive and the education they receive about their own physical health, I hope will compel them to seek services and to take advantage of what's been given them. And my observation is they're doing that. And throughout Minnesota, where I've been traveling the last 2 months, all the healthcare providers I deal with report an increase of our young soldiers and middle-aged soldiers coming in post-combat, which means they're taking advantage of what they have offered to them.
Are there any other resources available that members of the returning military and their family can tap into that has not been discussed at this point?
You're talking about health care.
Yes.
I would say to all physicians and family members to be aware of your county veteran service officer. So as you're thinking about how do I is this something to go to the VA, and how does the VA process work, and how do I get this soldier connected for an intake physical? That county veteran service officer is the gateway to all veterans benefits. I'll also put out the phone number that the state of Minnesota has created to link veterans and their families to all the resources. It's 1-888-LINK-VET, and that will connect physicians, doctors to a knowledgeable person who'll say, okay, this is how you connect to the VA or to the TRICARE resources or the people that can give you an understanding of how to be a better consumer of healthcare services.
You know, I want to throw this out here while we're talking about health-related issues and just see what y'all think about that. In each conflict that we've been in, there's been some health-related issue that's cropped up years after the fact, and they say, could have been thus and so during this particular conflict. I think Agent Orange comes to mind for the Vietnam War. Is there anything out there that you would worry about that could affect our fighting men and women years down the line?
One of our main concerns currently is TBI, or total brain injury. You know, the signature weapon in Iraq was IEDs, or improvised explosive devices, and things that go boom cause head trauma. And unfortunately, many times we will fixate on the amputated arm or leg or other obvious injuries and sort of forget that there had to be a significant blow to the head at the same time. Again, the majority of folks will recover from that in a few months or a year, but some will not. And when you look at all the other issues that a vet is having and then can't really mentate clearly, it really is problematic in negotiating all the health care that we just talked about, or negotiating the benefits because they might be separated, or determining whether they in fact can continue in the military, and to try and make all those tough decisions when not everything is operating normally is really a concern to us.
I think that's a very good point. Traumatic brain injury oftentimes is just so hard to get a handle on. I take care of a number of patients with traumatic brain injury who just have very subtle deficits. So you might not notice it in just the routine interview. It takes much more delving deeper into that problem to figure out what's the deficit there.
Yeah, mine is more of an anticipated problem. We saw this when the movie Saving Private Ryan was released. The VA reported a spike in World War II veterans coming in for help. The movie was very realistic, brought back a lot of memories. Men sought help. First person that gets Iraq or Afghanistan right in a movie, I think physicians can anticipate seeing some people coming in. If we have a precipitous withdrawal from Iraq and that country collapses into a terrible genocidal civil war, I think we can anticipate some significant depression. Young men and women who volunteered, proud to serve, seeing their efforts, the death and maiming of their loved ones, the people that they sought to protect, killed, we can anticipate we're going to see some mental health issues come from that.
By the way, in reference to traumatic brain injury, we'll be talking about that during a later show, because that is another whole topic to discuss. Final thoughts here, Dr. LeBlanc?
Again, I think it is important to ask any patient in your intake whether they served in the military, and if so, if they served in a combat zone, and use that as a springboard to look at other issues.
And Dr. Mock?
I would agree that just these are people who are trying to integrate back into their lives and through work and family and just doing your normal intake of how are things going will bring some of the things to the surface if there are problems.
Chaplain Morris.
Don't forget the entire family unit. They're a great diagnostic aid, and they're also struggling if the soldier's struggling. And they'll have all kinds of symptoms of issues that will need care as well.
Chaplain Morris, Dr. LeBlanc, and Dr. Mogg, thank you so much.
Thanks for having us.
Well, research has shown that the mental effects of combat do not always present themselves immediately upon a soldier's return home. But as we've heard, with the help of the healthcare community, family, and friends, soldiers can make a successful re-entry into their former lives. I'm Kathy Werzer. Thank you for watching.
Joining Forces, On the Mend, is a co-production of Health Partners Institute for Medical Education, a nationally recognized provider of continuing education for health professionals, and TPT's Minnesota channel.